All right, we're back. Hopefully you can all hear us again. Yeah, thanks again, Lauren, for that. And we'll start now with the variations in childbirth. So not everything goes straightforward. Like everyone probably hopes it could go straightforward, and everyone has normal vaginal births and no tears, no nothing. But it's not really the reality of every birth. So we're just going to touch on some variations that might happen. So sometimes it can start off now. Your baby, obviously, we want it to be head down in order to have a vaginal birth, but sometimes babies aren't, and could be in a breech position or posterior, which in that physio session, the optimal fetal positioning hopefully will enable that baby to get in that position being head down. If your baby is facing posterior or is in a breech position, some great things to check out is definitely Spinning Baby's website. So yeah, it's got some videos and just facts and stuff, and showing positions and other things that you can do to help get bub in that best position. And those positions, we won't go on about them because we just saw them in the physio presentation. And then external cephalic version is what we call an ECV. So it is a maneuver that doctors, obstetricians can perform to be able to turn your baby. So they usually give you a injection of something to relax your uterus, and with their hands on your belly, being able to push bub's bum up and turning bub inside the belly to become head down. It doesn't always work. It can be very uncomfortable, but it can also work really well and get your bub in that head down position. So unfortunately, we don't do them here at our hospital, but we can put in referrals and with your GP obstetrician if your baby is in a breech position down in Warrnambool. And they're able to perform it here. And if successful, then, hopefully then you can proceed to a vaginal birth when you go into labour a week or two down the track. So sometimes we need to induce someone's labour as well. So this is the artificial initiation of labour, so a bit different going in spontaneously on your own. So some reasons why we do induce people is that you've gone over your due date. At least you should go over to at least 41 weeks or greater. So usually around the 10 days post dates is about when we definitely want to start looking at inducing, but depending when that time falls can sometimes be changed around here. Other reasons could be to do with your blood pressure, if you've got swelling, protein in your urine, which could be all signalling that's preeclampsia. Sometimes your baby, if it's not growing as big as for the dates that not measuring to size, gestational diabetes as well, because that could have an impact on bub's growth, or low PAP-A. You would know about that if in early pregnancy, if you had that as well. Some medical conditions, they also might contribute to whether you need induction or not, depending on the severity, or potentially to do with your specialist in that area as well, what they recommend.
And if your doctor is talking about induction, sometimes it'll be sort of well ahead, and you can get a little bit sort of nervous about that. There's lots of things that you can do to help bring on your labour, natural things that you can do. We've got a whole list of them and we'll go through that with you. So if ever induction's talked about, just make sure that you're talking to your midwife as well, because doctors don't hand that list out, but we do, and we'll go through that with you and give all all the wonderful positive things that you can do to really try and get the labour started in a timely manner, so that you don't have to have an intervention.
Also with induction as well, it's important to ask your obstetrician or why, or like making sure that you get a reason behind why the induction is happening as well. And sometimes you can chat to your midwives as well. And Jenny and I always use this thing we call brain. Yep. And so use your brain when about anything in your labour,
when faced with something.
And it's so what are the benefits, what are the risks, are there any alternatives if I didn't go ahead with this induction or not, what does your intuition say as well, and what happens if you do nothing. So they're all different questions that you can ask, and you have the right to ask those questions as well. And if you don't feel comfortable sometimes asking those questions to your doctor, or you can speak to your midwife and they can ask those questions for you, because we're here to advocate for you as well. So don't hesitate. And all this should be done with your consent as well. So making sure,
it's our job to make sure that you understand anything that we do and that we have your consent for it. So you're not just the last thing we want to hear is I wasn't allowed to, or I had to have. That's not the language that should be in modern day obstetrics. It should be, well, I talked to my doctor and to my midwife, and the decision we made together was that it was best for me to have the baby induced because of da 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 da. You should be able to articulate that in your own words, so that you are fully embracing it and not just accepting something that you really don't understand. Oh, well, they said it was the best thing, so I just said yes. Or you didn't even actually get to sort of agree to it. You really need to feel like you can go through that process, and sometimes doctor's appointments, they're very busy and you can feel a little rushed. So by all means, have a chat to us and we'll advocate for you if there's perhaps more information that you've needed. So but jump in and don't feel frightened. We're there, that all the staff, medical and midwifery staff, everybody is there to serve you.
So some types of inductions, here at Hamilton we use these different methods, these 5 induction methods. So first one is a stretch and sweep of the membrane. So that's doing a vaginal examination, but actually pushing the membranes off the cervix and trying to stretch open that cervix if possible to initiate the release of hormones. So sometimes they work and sometimes they don't.
Pretty high success rate, really,
especially if your body is ready to get into labour itself.
That would be the sort of thing on your brain. Acronym would be alternative. It's like we're going to do something else. I was like, well, would an alternative perhaps be to have a stretch and sweep? And
start with that first, and then maybe a few days later, if that did nothing,
then another one.
And again, if that did nothing, okay, well, I think for the baby's sake, or depending on the reason, that we might have to go to a different alternative, or otherwise you might have already just gone into labour on your own. So the next thing is breaking your waters, so the artificial rupture of membranes, what we call an ARM. That's breaking your waters. Now your cervix, it has to be open enough to allow us to get our fingers in and to use we use a plastic hook to break your waters. So again, we hopefully will be able to show that in our little video we do next week. Or if we are going to perform it on you, obviously we would show you before what we were going to use as well. So we have to do a vaginal examination just before doing this to make sure that it's open enough and to feel the position of where Bub's head is as well. And then we're able to slide the little plastic hook in and break your waters. Okay.
So it should be no more uncomfortable than just having a vaginal examination. But in saying that, you know, some vaginal examinations, they are uncomfortable. It's also something we often do along the way. So you might have already started in labour, and if the membranes don't break on their own, sometimes we rupture them to augment labour, we call it.
Yeah.
In saying that, there's something to be said for having that nice spongy bag of 4 waters there, helping to dilate. But at some point, you know, later on, we'll probably say, let's just get these membranes out of the way and see if that stimulates that last bit. Yeah, if you weren't progressing, or, you know, there's a certain point where we'd probably like to see them rupture. The other thing is that we can see the colour of those waters, which helps us to determine a little bit more about the well-being of the baby. So,
but babies can be born in the waters too.
Yeah, they can. Yeah, born in the cord. They say those babies will never die of drowning.
Yes.
I think that's an old way of saying it.
Yeah, and I think it's very
rare.
Very rare, but in Chinese it's very, very lucky.
Lucky, yeah. I've seen babies, or a small baby, particularly once I remember nearly surfed its way out because the membranes came right at the end. It was a small baby and it wasn't her first baby. And it was like, boom, they went and outwished the baby all in one hit. So that's quite unusual. That probably won't happen to you.
Yeah. Another thing is prostaglandin gel. So prostans, that it's inserted into the vagina just under the cervix, and they're prostaglandins that can help ripen the cervix and help release hormones again too. So it enables hopefully to soften and start to open the cervix so that we're able in a few hours down the track, maybe 8 or so, to then be able to break your waters. And then, hopefully get labour going that way. Most common, probably what we use here, is the cervical ripening balloon. So it's inserted through the cervix, and a balloon is blown up in front of Bub's head, so only a very small balloon. Decent size. It's one balloon's blown up in front of Bub's head with water inside the cervix, and the other balloon on the vaginal side of the cervix is blown up. So it puts that pressure of those 2 balloons on the cervix to help open up. So, or a mechanical device rather than a medication. So that's probably the reason why we like to use it more, and we seem to have quite good success with it as well, of being able to open that cervix. We usually put that in the night before. You stay here and have the balloon in overnight, and then the aim is that the next morning we'll take it out and be able to break your waters as well. Again, we would, if you were to be induced, we would explain that in a lot more depth beforehand. But yes. Then, so once we've been able to break your waters, or if your waters have broken and for some reason you haven't gone into labour, we sometimes need to get the hormone drip started. So syntocinon, the synthetic version of your the oxytocin that's released in the body, and so that's the drip. And so we have to pop a cannula in for that. And we titrate this hormone up every half an hour until we get good, strong, adequate contractions, and that your baby's happy with it as well, coping well. So with that, any of these induction things, we usually have to have that CTG monitoring on at all times, and yeah, hopefully the wireless ones, so you can still get up and move around and do what you.
Except for if we just rupture your membranes and you get going on your own, we don't have to monitor with that.
No.
And stretch and sweep, we don't have to do any monitoring at all.
No. Yeah, that's what we need to do for induction. And if we do need to help out with birthing bub as well, so sometimes instruments might need to be used to help with the birth of bub. So you've got to fully dilate it, but bub just isn't coming down that pelvis for whatever reason, or it could be you might have an epidural and you might not be able to feel how to push. So sometimes we do need to assist with the delivery of bub, and if bub is facing the right way and in a good position, then hopefully we can assist with these instruments to help deliver bub. Or if bub's for some reason heart rate's dropping, or not coping well with the contractions, and sometimes we need to speed up the birthing process, and if we're fully dilated again, we're able to use, and bub's in a good position to be pulled out vaginally, we're able to do this. So using the Kiwi cup or ventouse, so suction cap on bub's head, you still need to push with using this, so it just aids in helping assist bub's head come down, but you still have to push, and we pull with this during the contraction, or the doctor does. Otherwise, forceps, so sort of like salad servers around bub's head, to help pull bub's head down or turn bub's head so that it can be birthed vaginally. Any of these assisted vacuum births, and if it's your first baby, we would recommend cutting a episiotomy to help reduce the risk of 3rd and 4th degree tears, and allow a lot more room for those devices to be put on. So an episiotomy is a deliberate cut into the perineal area to allow that wider diameter. Yeah.
Okay, we'll just talk about perineal tears. There's been a lot of work done in recent times through Safer Care Victoria, introducing a bundle of measures to reduce the incidence of 3rd and 4th degree tears. Sally's done a lot of work on that with a small team to bring it into our hospital. We thought that it was important to introduce those measures. So it's very common for the perineum to tear during a vaginal birth, and most tears will simply need to be stitched and will heal well, and sometimes they don't even need to be stitched. There might be just what we call a 1st degree tear, which is just skin, and that is sitting together nicely, and it's actually almost worse to stitch it. It's sort of more invasive to stitch it. However, if it's what we call a 2nd degree tear, then we definitely will stitch it with good light and getting you into a good position. The bed does magic things to get you into a position where it's easier for the doctor to repair that. Although some tears are worse than others and can affect your broader health and wellbeing. So we want to, part of the bundle of measures is that we, if we do have a tear that's more significant, that we diagnose it appropriately at the time, and then we get that repaired in an appropriate setting. So if it's a more severe tear, which hopefully with the other things will stop us having those, and we've actually, even with our relatively small numbers here in Hamilton, we have seen some really good things out of it, and I feel like we're really making quite good advances. I think we all feel like that. Yeah,
and I think in the state at the moment we're currently reduced it by, we're trying to reduce it by 50% by July 2020. We had to delay that because of Corona, but I think we're up to at least 25% reduced at least a month or two ago, so hopefully that's working.
Yeah.
So we've taken these bundle of measures and applied them to our practice. Most of us were doing these anyway, I think, but just making sure that we definitely do it for every woman. And these are to aim to reduce or minimise the impacts of these tears. So, of course, we would probably explain these to you. I think most of the midwives do at your one-on-one sessions, and we will do these with your consent if you're happy for us to. So applying a warm compress to support the perineum during the second stage of labour, and when we're seeing especially the crowning of Bub's head with your first baby, and hands-on technique for the birthing your baby. We, with your consent, would cut an episiotomy if at an instrumental delivery, if it's your first vaginal birth. And also after the birth of your baby, it's recommended to do a rectal examination to make sure that there's definitely no buttonhole tears. So they're a tear that you can't see by just looking. You need to sort of feel through the anal area. So we recommend doing that for everyone, and again, doing that with your consent as well. I'm just going to check this message.
Is that the end?
Just the next one.
No.
Next, just that one. Oh,
I couldn't quite see the arrow. Oh, it didn't go. There we go. Caesarean section. Probably most of you have known somebody who's had a caesarean. It's obviously an abdominal surgical operation to remove the baby from the uterus. It can be planned prior to the labour or an elective Caesar. That would be if you had breech or some other medical condition or condition of the baby that it was not advisable to have it vaginally, once again with your input and consent. Any time during labour, we would call it an emergency caesarean, but it's not necessarily like a bells and whistles, like an ambulance roaring down the road. It's might be that that you've you've been in labour for a long time and haven't progressed, or something like that. So yeah, I've already mentioned breech. They're quite common in Australia and around particularly the Western world, but not so common in more third world countries.
Again, with that link that Eve Shepherd with the video put up about epidural, I think that link also has some on that website, some good things she said about caesarean section. So we will send out that link and you can have a look at that as well.
So, is that yours or mine?
It's yours. So with the caesarean, when your baby is born, it is the doctor will hopefully be able to show you your baby over the top of the drape, and you can see what sex your baby is. Then your baby is handed to the midwife, who's dressed all in a beautiful gown, and taken to the resuscitator just to quickly check over your baby and bring it over to you, because it gets a bit cold in theatre. We just want to make sure your baby's wrapped nicely, and we try and do, if you're feeling well, some skin on skin in theatre if appropriate, or if you're not feeling well yourself, we can also do some skin on skin with your partner or support person as well. So we try as much as we can, but sometimes you're feeling unwell, or sometimes there's a medical reason why we can't do that skin to skin in theatre, but again, as soon as we get to recovery, we're definitely trying to do that skin on skin and initiate that first breastfeed in recovery as well. So Jenny, I think, touched on some reasons for caesarean. So elective caesareans, hopefully we've already chatted to you about the reason why you need an elective caesarean. There's a list here, so placenta previa. You would know about this hopefully earlier in your pregnancy when we do the ultrasounds earlier in pregnancy, and that tells us where your placenta is sitting. So this placenta previa is sitting on the cervix, so that means that the cervix can't open without that being cutting off the blood supply to that placenta. So that's the reason why you need elective caesarean. Sometimes preeclampsia you do, depending on your blood pressure. Baby size, twins, breech. Unfortunately, we don't do breech births here. If baby isn't growing and for some reason vaginal birth's not recommended, or a previous birth experience as well. Reasons for emergency caesareans: a baby might be distressed, heart rate's not good, or no progress in labour, and yeah, there might be evidence to say that from even going through all of labour that your labour is not progressing, and it might be recommended to go for a caesarean and not able to have a vaginal birth. Baby could be facing the wrong way or head not exactly in the right position, or prolapse of the cord, so the cords come out before the baby's head or body bit. So they're reasons for emergency, and again, hopefully we'll explain definitely why she needed to have that as well. So types of anaesthetic having your caesarean section would be, if you've already got an epidural, we might be able to just use that, or generally a spinal anaesthetic is the main one we use. If it's a real emergency or there's a reason why you can't have a spinal anaesthetic, sometimes a general anaesthetic is required, and especially if we need to get that baby out really quickly. With the general anaesthetic, that means that you're put to sleep, and we don't allow partners in the theatre if that's required, but we'll bring the baby out to your partner as soon as possible. But most of the time it's a spinal anaesthetic where you're awake but not able to feel any pain.
So recovery after a caesarean, midwife and nurse will care for you. We check everything out very frequently, including where your pain's at, just your vital observations. Blood pressure is done a lot. Vaginal loss, the actual wound site. We also will assist you with feeding and baby care. We probably pretty much every time with first time parents, the partner was already planning on staying with you, and that's incredibly useful overnight because you won't be able to get up and tend to your baby, so it's great to have somebody there, and we'll provide a chair for you to sleep in. That's whether you have a normal birth or a caesarean. You'll have a catheter and an IV drip overnight. Generally here we are using what we call a PCA, which is personal controlled analgesia, or patient controlled analgesia. So that means you just have to press a button and you get a small amount of pain relieving medication to help you, measure it according to what your needs are rather than having to wait for something to come. So we really like those here, and I think most of the anaesthetists are using them now. You'll be able to eat and drink after the surgery, and if you've been going through labour, we just have to record when you last ate and drank. But if we're suspicious that it might go down that track would probably get you at least stop eating, but often you don't feel like eating a lot in labour anyway. Early ambulation is probably the most beneficial thing you can do to reduce complications, but also for pain relief, because you get a little bit stiff and sore in bed, and so we want you to have enough pain relieving medication along the way in order that you can get up and about and walk, because then you're in an upward cycle. Because you're moving, you need less pain relief, and because you just keep going on the up and up. Most women having babies are young, fit and healthy, and so they do recover very well, but you have had major surgery, and I think we really have to remember that. Even us, sometimes we look and you just look so great, but we have to always have in mind that you have had major abdominal surgery and it does take some getting over. Your stay in hospital varies according to need, but it's usually two nights and 3 days. But like any birth, sometimes that has to be flexed. Not very often less than that with a first-time baby, because you need to have that time to get a little bit of confidence with feeding and recovery. But sometimes it's probably more likely to be slightly longer. But it's all very much tailored according to your needs. And yeah, it says partners can stay with you to assist with the baby. We really strongly encourage that.
Yes. So this is just some complications that can also happen. So we spoke about the tears. We recommend ice and salt baths as well, especially you can do them here in the hospital or at home 4 to 6 weeks to heal.
And if you don't have a bath, to have a salt bath, one really good way of doing it is just to either splash some salty water onto your healing episiotomy or tear, but even the spray bottle with salty water in it can be helpful as well. And patting it dry with a soft towel and then a hairdryer, cool hairdryer, not a hot one, on the site just helps to sort of promote it to be a little bit dry and heal up a little bit quicker.
Yep. Postpartum hemorrhage, so that's a bleed after birth, so it can have implications for a slower recovery, but depending on how much you lost and how much blood you had in your system beforehand as well, and what your iron levels and that sort of were as well. Gestational diabetes, or small or really quite large babies for age, may need some blood glucose monitoring, but again, we would discuss that with you if they were required. And again, gestational diabetes, hopefully you would know about this if you were, and your midwife would have gone through that, and also the diabetic educator as well, and through things that we can do to help. Cool. We've got Jess here from the Australian Breastfeeding Association, so she's just going to do a chat as well.
Right, lovely. Hello, everyone. So my name's Jess, and I am a volunteer with our local Australian Breastfeeding Association group here in Hamilton, catering to Hamilton and surrounds. So today I just wanted to introduce you all to our local support services, as well as the national support services that are available to you to help you through your breastfeeding journey if you choose to breastfeed. So our local group is made up of 3 trained breastfeeding counsellors, of which they're all volunteers. We have another 3 breastfeeding counsellors in training at the moment, and then another 3 just general volunteers like myself helping out in the group. So ABA is Australia's leading authority on everything breastfeeding. So it's where you can go for that up-to-date research and evidence-based information and support. And if you are choosing to breastfeed, we are here to help you achieve those breastfeeding goals. So for some, it comes really easily, breastfeeding, but for other people, it can sometimes be quite difficult. So it's just letting you know that breastfeeding is not black and white. It's not all or nothing. You have many options. If you need the support, ABA can help you to troubleshoot through things, from fully expressing breast milk and bottle feeding, mixed feeding, or even if things don't quite work out the way you planned and perhaps you are wanting some counselling or support through that grieving process or any disappointment around not being able to achieve any breastfeeding goals. ABA is here for you in that way as well. So to give you a little bit of an idea of the services available to you, first of all, at that national level from ABA, it's really important to know that there is a 24/7 breastfeeding helpline that you can call. So I'll just kind of, hopefully I get the angle right on the camera here, if I can. So we can send these as a link afterwards. So is that to front? No? Might be. So there is I'll tell you how to find it online and in the app as well, but there is a 24/7, 2 a.m. in the morning, you're struggling, you're needing that help, then it's great to know that that service is available for you to chat to a trained counsellor. You can also access the website, which is full of information, and as I mentioned, that evidence-based information for you. There is web chat available on the website from 8 till 10 p.m. at night, so you can actually chat online to somebody that can help you navigate through the site, get the information that you're after as well. And there's videos giving you practical demonstrations on how to perhaps troubleshoot through feeding. There is a plethora of books and resources available for you to order as well. But really the free information that's on there, you don't have to be a member to access it, the helpline or the website or web chat. So just know that that is there available to you, and partners that you can ring up the hotline as well. It doesn't have to be the breastfeeding mum. So at the local level, we have, as I mentioned, 3 local breastfeeding counsellors. Unfortunately, due to the COVID-19 at the moment, like most things, we aren't able to run our normal monthly catch-ups, but when they are on again, they are the first Friday of the month at Hurl. And everybody is welcome, breastfeeding, not breastfeeding. If you've got one child, multiple children, friends, grandparents, partners, everybody. It's just a really open place for you to come along, perhaps chat to a counsellor, or just come for that social support, or just get out of the house, really. So that's at 10:30, that first Friday of the month. And then we do, for members, if you are a member of ABA, there's a nature play, usually, not at the moment, the 3rd Friday of the month as well, and that's at Hurl outside, just outside. And so, as mentioned, at the moment that's not available. But what we do have is our local counsellors are more than happy for you, particularly at the moment, to contact them directly as well. If you want somebody local to chat to, you probably won't appreciate a call 24/7, 2 a.m. in the morning, but if it's sort of during the day and you want to give them a call, I'll tell you where you can find their numbers, but you can also send them a message on the Facebook group site, Facebook group, and reach out that way as well. So through our local group, we are still hiring out breast pumps. If you did need one short term, or you're looking to get a bit more assistance, help, information about one, try it out and then buy one, we've got Kelly who's available to help you through that. And members get a discounted rate of hire for that as well. So, and we have a group email that you can reach out as well if you want any form of support. No problem's too small. If it's just to talk through something and get reassurance, or if you have a bigger problem, our counsellors aren't going to anything in the clinical realm. They'll refer you on if it's not appropriate for them, but for general breastfeeding counselling advice, they are more than happy for you to reach out and chat to them. So just to let you know how to get in contact. One thing that is really great, if you are all wanting to have at your fingertips how to access ABA, there is the website, but a great app, and I'm just going to try and put it on my phone if the camera is going to allow it. So you can see the logo. No, it's a bit glary, I think. But the Mum to Mum app, it's a little blue logo with a mum holding a baby. So it's Mum, M-U-M, the number 2, M-U-M. And it's by the Australian Breastfeeding Association. It just gives you access to the support at your fingertips should you need it. So when you go into it, you can click connect with ABA, and there you go. You can ring. It's got the contact straight to the helpline from your mobile phone should you need to ring the helpline. It's also got a link to the website for you to start looking through their information. Or they've even made it slightly easier to navigate around the common topics of breastfeeding information, where you can just jump on directly from the app some common advice that you may be seeking. So if you connect with ABA and go to the website, type in Hamilton, Victoria, and you'll find our local group with our group leaders' contact details, our counsellors' contact details, our email, how to find our Facebook group. It is one that you will have to request to be a member of, but just click the they'll let you in basically, and then that's a really great way to find out what's going on. There's been some online chat discussions in lieu of not being able to have meetings that you can jump on, and if you go to the photos, you'll see our latest bulletin, and that has direct numbers there to all our counsellors if you want to contact them directly. Send them a message, but send an email, send a Facebook message, send a text message, or call the helpline. You've got a huge range of options, however you feel more comfortable. Yes, so hopefully that covers most of it for you. Membership is something, if you were interested, we are a volunteer organisation, so the money from memberships does obviously help, and you can get a great book, which is a Breastfeeding Naturally book, which is a bit of a Bible for you to go have a read through, and lots of information there for you, as well as emailed out magazines for you to keep up to date with what's going on with breastfeeding, as well as the Nature Play benefit from being a member, monthly Nature Play that you can come along to, that's as well. But I'm not much of a salesperson, so I won't harp on about that too much. I just want to make sure that you're aware of all your options. Don't hesitate to reach out. We're all very friendly and open, and there's no question or worry too small, basically. All right, thank you.
Thanks very much, Jess.
Thanks very much for coming in.
Thank you. It's appreciated. Bye-bye. So, breastfeeding benefits for babies. Well, it's a complete, easily digested whole food for your baby that adapts during feeding and over time to meet your baby's developing needs. And over time, not over time, over time to meet your baby's developing needs. The thing I really love about breast milk, there's so many cool things about it, but one of them is that if you happen to have a premature baby, did you know, interesting fact, did you know that your baby will be receiving different milk to if you delivered a full-time baby, full-term baby, full-time.
You're all full-time.
Yeah, full-term babies will get different milk to premature babies. And also, if you're exposed to something, just even the common cold, and I'm assuming coronavirus would be the same, you develop antibodies that are passed on to your baby through the milk. So your baby naturally receives immunity. There's also lots of immune boosting properties in milk, particularly colostrum, but all the milk. And it just keeps on adapting and changing as your child goes through. Whereas on the other side of things, formula, it's just one sort of product. It doesn't change. It doesn't adapt. Or you can get different ones for toddlers and things like that. But essentially, anything for a baby is from 0 to 6 months, and it's just the same. Whereas colostrum is a very small amount and really concentrated, and just loaded with goodies for your baby to set their gut health up. Formula is exactly the same for that tiny baby, and they need to have a lot more fluid in order to receive the nutrients required. So a baby is just perfectly set up in their anatomy as well with their tiny little tummies. Have we got those little balls?
Yeah, I do.
Yeah, so a baby's tummy is really tiny when it's first born. I'll just show these. This is probably something that your midwife will go through with you as well, one-on-one. But the tummy is only the size of a tiny little marble at day one, and that holds 5 to 7 mils. Okay, so and for a baby to first 24 hours is about 15 mils, which is 3 teaspoonfuls. So that tummy only taking 5 to 7 mils is the exact right size that it needs to be for your baby, for the milk that's the colostrum that's available. And then it moves up to 14 to 16 mils on sheet of marble. That's the stomach capacity by about day 3. I just have to read the thing to remind myself. So by about day 3, we've got a capacity of 14 to 16 mils. So by then, your milk is starting to transition into mature milk, so there's more volume of it. And then by the time they're 10 days old, the capacity is a ping pong ball, and it's 60 to 80 mils. It's sort of hard to see on there, but so that's the 3 size balls. So your body is working perfectly in synergy with your baby. Childhood illnesses are much reduced during breastfeeding. Ear, respiratory, diarrhea, gastrointestinal and urinary infections are all much, much reduced for the breastfed baby. It reduces the risk of SIDS, sudden infant death syndrome, and it also reduces the incidence of dental caries and helps with facial jaw development. So it's got lots of reasons to embrace it. Maximises your breast and ovarian health, reducing the incidences of cancers. So there's benefits for both sides. Increases your bone strength, which is interesting because calcium is drawn out, obviously. Any milk has calcium in it, and so does breast milk. But because it's actually being drawn upon, it actually, your body knows to lay it down again. So that's actually a protective with osteoporosis. It conserves iron stores by delaying your menstrual periods returning. It does provide some fertility control in the first 6 months. We tend not to suggest that you rely on it entirely, but in developing countries, they really do breastfeed their children very, very frequently. They basically carry them around for the first couple of years of their life, and they do tend to space those babies out by about 2 years. So it does have a pretty good effect. But we do suggest that you use something in addition to that for fertility control post-baby. Thing I really love about it is that it helps use up the body fat stored during your pregnancy. So you lay down body fat for that reason, so that you can breastfeed even if food sources are a bit low. So you'll just naturally use up that body fat. Hopefully some people find it's very effective. Other people say, nah, didn't lose it till after I finished breastfeeding. But personally, I found it very good. I could eat what I liked. Assist with bonding between you and your baby. We've talked about that with that skin to skin. It's a beautiful thing. And interestingly enough, the baby's sight is exactly the distance from breast to eyes that they can sort of see. After that, it gets a bit blurry. That's why they're very focused on you and your round face and your round eyes, and they love that round breast and that round nipple. They're very attracted to anything round. It's inexpensive because it's free, and it's portable and easy to get out and about. Time saving because you don't have to wash, sterilise and make bottles, and it's always the correct temperature. So it's got some pretty big positives. It can be a little bit of effort getting it up and running, but, it doesn't some people think that if they formula feed, all their feeding difficulties will be gone out the window, and that's not necessarily the case. Babies are interesting creatures, and they do have times of being unsettled, whether they're breastfed or bottle fed. So we really encourage that if you feel like you would like to really persist, we will go with you as far as we need to, and we'll always find the other supports for you as well.
And it comes at the correct temperature, so there's no need to wash those bottles and everything like that. You can do it anywhere you like. Just yes.
And it's just on that note, should you be out breastfeeding in public once you can get out a bit more with this coronavirus, if anybody was to come to you, say in a cafe, and say you shouldn't be breastfeeding here, your baby has the right to breastfeed. And just if you think about that, I'm not breastfeeding, my baby's eating, is probably just a slight little mind shift. And you know, people don't even know that you're breastfeeding. You think everybody's going to notice because you might feel a little bit, you know, self-conscious. But there's no need to, you know, just do what you need to do so that your baby doesn't have to wait because they don't know weight.
Yes, that's right. Also, just in regards to corona, studies have been done that even a mother with coronavirus, it's still recommended to breastfeed. So that wouldn't change. And hopefully we don't have any of those cases here anyway, but just so that you're aware of that. And we still keep mothers and babies together as well in terms of that. We might just get the mum to wear a face mask. So breastfeeding your baby, we just recommend on demand. So when your baby wants it, and that's usually around that 8 to 12 feeds within a 24-hour period. So your baby might want a cluster feed all throughout the night so that you don't get any sleep, and then break it up during the day. Ideally, hopefully, all those cluster feeds are during the day, but babies don't know ideally. But around about that 8 to 12 feeds, sometimes in circumstances we may need to prompt babies, but again, that could be, that's on an individual basis as well. But there's a little chart sort of thing there as well. And we're looking at baby's output as well. So as long as a baby's weeing and pooing, that's also indicating that a baby's got has had enough milk too, and weight is also a good indication as well.
So that chart there is that was what your grandmother might have seen in her child health book many, many moons ago, and it was expected that a baby should be able to sleep from 10 till 6, but you just stop and have a little think about it. How often do you pause and have a little sip of water, or, you know, maybe a little snack, an apple or something like that? You know, even in the night I'm taking sips of water, so it's pretty unrealistic for a tiny baby who's getting all of their needs met through you to go from 10 till 6, for goodness sakes, that's 8 hours without anything. So expecting them to sleep in that time would be extremely unrealistic, and much better to just feed them on demand. This is the reality clock, yeah. So, you know, there's still space in there. The baby's still sleeping a lot, but they are feeding, and you'll notice that there's lots of cluster feeding in there from about 4:30, and this isn't every baby, of course, they vary, all babies vary, but 4:30 p.m. to 7:30 p.m. they're having 1, 2, 3, 4 feeds. And that's because oftentimes your supply is just slightly reduced by day's end, and it's also just happens to coincide when you'd rather like to get dinner. You know, it's all just, you know, maybe the day's just not quite going according to plan, and baby just wants to be quite, you know, close to you. So it's better just to really pretty much drop everything and just feed your baby. But another way of going forward is to baby wear. I'm a really big fan of that. If you've got your baby tied onto you, it's best to use, there's some really good devices out there. I always would look for ones that are chiropractor or physiotherapist or midwife recommended. Something that, you know, particularly physio is not going to be hard on your back. And some of them are really fancy, and you can put them onto, like, have them on your back when they get a bit bigger for hiking and whatnot. But it means you've got both hands free, the baby's right there close to you, you know, and then all you have to do is just sort of sit down and maybe get your breast out and give them a quick feed, and then back up again and off you go. And So it might work well for you to do that. And yeah, the overnight feeds, they're beautiful. And, you know, it won't be very long when they'll start cutting some of those overnight feeds out. But babies don't know any difference between day and night. They don't come with an inbuilt clock. Some people say, oh, they've got their clock back to front. No, they haven't got a clock at all. And so, you know, they'll feed whenever they need to. And quite often the nighttime feeds are actually seen to be a bit more efficient because there's nothing to distract them, like bigger babies sort of start getting distracted sometimes, so they'll actually take some beautiful feeds at night.
Most healthy newborns don't need to be woken for feeds, although, as I said earlier, some cases we might need to start promoting feeds with babies and trying to wake them. But again, your midwife would be sort of educating you how to do that, or if it needs to be. Yeah, there we go. These are some cues that your baby is ready to feed. So usually crying is one of the latest cues, and your baby has become frustrated and probably hungry, and that's why it is crying. But if we can try and pick up on these early feeding cues, then it's easier to feed, get a baby attached when they're not really frustrated. So picking up on these little cues of opening their mouth, looking around, sucking on their hands or fists, stretching, increasing their bodily movements. Yeah, and especially those sucking sort of looking around.
They look like a little sparrow. Where's my word?
And then, of course, this is when Bub's already given some of those feeding cues earlier, but now is frustrated and wants to food. So sometimes we've got to soothe the baby, so by cuddling and doing a bit of skin-to-skin contact and calming a baby before then trying to attach it. So supply equals demand. So most mothers worry about how much milk they have or not having enough. But the more you feed your baby, the more your body's going to make that milk for your baby. And as Jenny showed with the ball sizes, a baby's stomach's quite small, but might want to feed sometimes more often to fill that up as well. So the more your baby feeds, the more milk your body's going to make as well for your baby, and that milk should be made exactly for your baby's nutrients needs as well.
Pretty much any issue you have with feeding is solved by keeping the milk moving. If you just keep that little statement, keep the milk moving, it really does. It solves so many issues. Okay, so a lot of people want to know, but I don't know how, you know, if the baby's had enough, you know, if we're feeding a bottle, I can see that the bottle, you know, the amount's going down, and I know they've had 40 mils or whatever, and I know that's enough for them because that's what the tin says. 6 to 8 wet cloth nappies or 5 to 6 disposable nappies in 24 hours shows you that your baby should be getting enough. This is once your milk is established. In the early days, we're only really looking for 1 wet nappy in the first 24 hours, 2 in the second and 3 in the third, but generally we get more than that. But that would be the way to tell if a disposable nappy is wet or not is there's most of them have got a line on it that changes colour, and you can also tell because the core of the nappy is made of material that absorbs the fluid and it becomes squishy. So sometimes people will say, oh, I couldn't tell because there was a great big poo in there, and but you can sort of tell because the core of the nappy has got a squishiness, not just the squishy poo.
Yeah.
So it's worth knowing whether you've had the weasel poos, because that really helps us to know more about the wellbeing of the baby. We're not there all the time, so we'll show you how to fill in your feed chart, and we really appreciate it when you do it well and try and know whether the poo has got wet in it as well. You should have baby should have 3 or more soft bowel movements. So it starts off that sticky black movement called neck. It looks like licorice, and then it moves on to sort of more like treacle, a bit browny and a bit runnier. Then it goes on to, it's all food, pea and ham soup is the next call, where it's green with sort of blobs in it. And then it goes on to scrambled egg or mustard, which is yellow with blobs in it. The blobs, the white blobs that you see in a baby's poo are the milk curds. So that's all very normal. So yeah, the black sticky stuff, it's can be a bit overwhelming when you see it. Sometimes you see it coming out of the baby's bottom, that they're doing it right before you, and it's like a volcano going off. And you, oh my gosh, how am I going to do this? So, just probably use a big face washer and try and get it off like that, because if you dab around with
you'll go through a packet of wipes.
Yeah, exactly. Good skin colour and muscle tone, that really shows us that the baby's doing well. Alert and reasonably content, so that doesn't mean that they sleep and feed and never cry. A baby's only communication is with crying, so we do expect crying around the house, but if they have times of being content, it's another really good indicator they're getting enough. And we're looking, after we have an initial weight loss, in the first few days, we look for starting to get some gain by the end of the first week mostly, and the maternal child health will be measuring the length and the head circumference, which should also grow.
So some common problems, sore nipples. You can expect some initial tenderness of the breast. You've never had a baby sucking on your breast before, so they've got to sort of toughen up a little bit, but we don't want it to be if the painfulness to persist, it's because the attachment's probably incorrect. So that's when we need to really work on that attachment with you, making sure that really nice wide open mouth is bub, and getting that good amount full of the nipple as well. So sometimes different positions, making sure your nipple's shaped in a good way as well can help. Sometimes there's issues with the shape of your nipple, and but again, your midwife would be chatting to you about that, and whether we need to use any other devices or not. Cracked nipples are other things. So if sore nipples left untreated, they can become cracked and bleed. And so sometimes we need to use different creams as well, and sometimes even resting the nipples if needed to be. Again, if we're resting the nipples, we need to make sure that we're still what's my word? I'm saying stimulating the breast.
Getting the milk.
So we might need to use the breast pump or hand expressing and pretend that the baby's stimulating the breast, but not actually attaching to the nipple. So hopefully if we can try and either heal those nipples or work on that attachment, you might have some tenderness, but it should settle after about the initial 30 seconds. So we would work on all different sort of things for you there. So nipple creams, you can get these hydrogel breast pads as well to help heal the nipples. Just make sure you only use sort of one of those remedies, not all of them, because they work in different ways of trying to heal the breast as well.
And the first basic one is actually expressing a little bit of milk at the end of the feed, and just rubbing that into the nipple. That's really good nipple conditioning. That's all you need to do, unless they become very tender or damaged in some way. And then we would still do that, but add some nipple cream or the dress discs. There's a special cream you can get from down at James Dean Pharmacy. It's made up by the pharmacist down there called Rob. And it's worth getting if there's significant damage. It just really helps heal them up quite quickly. It's got a few ingredients in it.
Engorgement, so swelling of the breast. That can be when the breasts are so full, but we need to drain them baby's not draining them for some reason, or they just haven't started flowing yet, but they're very engorged and painful. So we've got to make sure that the attachment again is working well. So your baby might not be draining it because it's not attached well. So we'll work on the attachment using hot and cold pad compressors on the breast. So especially before a feed, using warm and then cold afterwards, or a shower. Cabbage leaves can be great. So sometimes getting having some of them on hand when you're going home as well, and usually settles between 24 to 48 hours, but it can be quite painful, and you sometimes need to take Panadol and ibuprofen or something to help with the pain of that as well. Mastitis, so inflammation of the breast. So when you might notice that you have lumps in the breast and then they've developed redness and are quite painful as well. You might also get flu-like symptoms, so high temperature, chills and aches. And this has come from a milk duct that's got blocked and it's not cleared, so bacteria is built up. And ways, if you do notice lumps in your breast, best to keep massaging them out, and hopefully that doesn't develop into anything further, but occasionally they can get blocked, and that this bacteria can start up an infection. So recommend continue breastfeeding.
It's not the time to wean.
Definitely, you'll make it even worse. Warmth to the breast, again, especially before a feed, to help try and drain off those milk ducts. Pain relief, such as Panadol, gentle massage to the lumps, especially when we're feeding or expressing, and breastfeed from the affected size first. So we're trying to unblock that duct as much as possible. Sometimes we do need to put you on antibiotics, and they might be just orally or sometimes IV. They need to be given as well if not clearing.
There is a product you can get, a probiotic product called Kiara, QI, it's not got the U in it, QIARA, I think it's spelled. Probably something that if you did have a bout of mastitis, it'd be really well worthwhile looking into that. ABA would certainly be able to push you in the right direction. And yeah, that's something that they have found to be very beneficial because it's got the right probiotics contained in it for the bacteria that's naturally present in your breast. So they think it's a bit of an imbalance for some people. That's why they get continual bouts of mastitis. So yeah, I probably wouldn't just go running down to get it because it might be an expensive thing you just never even needed. I think it is pretty expensive, but well worth it and much better than having to have continual bouts all the time.
Yes. I think physiotherapists can also do some ultrasound on breasts too, so that would be something to look into as well if you did develop some mastitis as well. So
should we do the box just us?
Yeah, I was thinking maybe we could do that.
We normally do a little game. We try and break things up a bit, but it's a bit hard to when we sort of have with our different speakers. But we've got a box of tricks here that we give out to the people in the class that basically we want you to tell us what each of them could be to do with breastfeeding. So what we'll do instead is I'll pass them to Sally and then I'll read out what it's for.
So I've got a baby's bottle. So, well, hopefully it's not to give the bottle to the baby, but this is to do with breastfeeding.
So maybe it's to do with using a sipping cup to go directly from the breast to a cup instead of having to have a bottle in between times. Mind you, that one is a little bit bottle looking in the teat, isn't it? I'm not sure where that one came from, but my kids did. They never had a bottle in between times. But then these days, most people do try to introduce a bottle because it can be convenient for them not to need mother for a breastfeed all of the time, especially as you get further, like they get a little bit older and you maybe want to return to work and not leave them behind. But, you know, most workplaces are pretty accommodating with breastfeeding breaks. Okay, we've got something
All right,
else.
so I've got a clock.
So clock, 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 tickety tick, tick tock. Okay, so just thinking about that, that breast is always there with you wherever you are. Most babies, when they're little, are with the mother wherever she is. So I guess it saves on some time.
Yes. Oh, don't have to get up and clean those bottles. And
Yeah, exactly. Get ready for the day's bottles. Yep.
I've got a diploma.
Yes, I think that's what it's meant to be. A little diploma. So breastfeeding your baby has been likened to, it is actually a diploma, likened to helping your baby to reach their full potential intellectually. So it doesn't make them smarter, but just their full potential.
So I've got a measuring tape. And could this be to do with baby's growth? Or
No, it's not. It's actually, remember I said about the fat that you put on during pregnancy, it was meant to.
Oh, that's
you get to lose it when you use it for what it's meant for.
better than baby's
So
growth.
you're returning your waste back. And it also, not only the pounds, but or the kilos, but also the uterus gets to return back to its original pre-pregnancy state quicker when you breastfeed, because oxytocin, it's the hormone of labour, love and lactation, and it will help you to get that uterus back down into the pelvis where it belongs after you've had the baby. So your waist goes back to normal.
Perfect. Temperature? Is it my breast milk comes out at the correct temperature?
Oh, yes, it would be. This is an easy one.
Ooh. Saves me some money. I've got a little coin
There's
purse.
something in it.
Oh. Ah, yeah, lots of monies.
Yes, formula can get quite expensive because as the baby grows, they need more and more and more. And yeah, you've got to feed yourself. So if you're making milk, you're basically getting it milk for jam.
Oh, I don't have to take that pill anymore, do I?
Yeah, it's actually not the mini pill, that's a combined pill. That was all I had. Yeah, it's meant to be an empty pack of mini pill for fertility. Yeah, we recommend if you are going to use the pill that you actually use not this one, a combined pill, you use a mini pill, and that is a progesterone only, so it doesn't impact your breast milk. Yeah, that slightly slower return of your fertility, as we mentioned before about keeping your iron levels up as well. This is a good one.
I've got a nappy. So is this to do with our output of our baby, or?
It's actually about smell.
Oh, yes. That breastfed nappies don't smell
As much.
They
still smell
well, those dirty mech ones, they don't smell at all.
Yeah.
But they don't smell near as much as what a formula-fed baby does.
Picture.
I've got a little picture of a mother lying down with her baby. Is this to do with nighttime feeds? Or?
Well, it could be a lot of things probably, but it's actually baby bonding. You can bond with your baby when you're breastfeeding and not bottle prop. We wouldn't recommend that if you're bottle feeding either, but bottle propping is not a good idea. Yeah. But the breast, you've got to hold your baby, so it's great. Yeah, it's great.
I've got a little car. So is this to do with
yeah.
portable?
Yes. There you go. There the breasts follow. Okay. And
a toothbrush. Was this to do with the development of the baby's mouth?
Yep. That's exactly right. The dentists really don't want your baby to have dummies or bottles or things like that, because the sucking action is quite, they don't, not that they don't say no you shouldn't or no don't or whatever, but they really can see the difference in a jaw development with a breastfed baby to just have everything lined up perfectly the way it's meant to for their teeth development and their jaw development.
Oh, I got a tampon. Hopefully breastfeeding doesn't make me return to get my periods quite as quick.
Return a cycle, yeah. Some usually would be somewhere between 6 and 12 months probably your cycle might start coming back. If you were going to more or less rely on breastfeeding as a contraceptive, you would need to be breastfeeding at least every 4 hours right around the continuum of the 24-hour clock. So that would mean, a couple of nighttime feeds most likely, and it's generally coincides with that next pregnancy, if you're not using anything else, would coincide with when you dropped a nighttime feed and you were all of a sudden getting six hours a night. And of course with that you are probably in the position of wanting to do what makes babies more often.
So Hamilton Medical Group appointment card. What's this to do with?
You might remember during that little chat we talked about babies going to the having infections and things. There was less gastrointestinal infections, less ear infections, less upper respiratory tract infections. So therefore less
of these.
Yeah, which is more money and more time. Yeah, so
all right, that's our little box of tricks.
Yeah, I don't think we've got anything else, have we?
No, I think that's so. But thanks for joining us today.